Operating on a 27-year-old female patient, and her refractive error right eye minus 3.75 diopter sphere with minus 1 cylinder at 67 degrees, improving to 6.6 N6, and left eye minus 4 diopter sphere with minus 0.5 cylinder at 180 degrees, 18 degrees. And the procedure she will be doing is both eyes ReLEx SMILE. Over to Dr. Rupal.
Thank you. Thank you for the generous introduction. It is definitely acting as a tequila shot, which I really required at this time. The pretty girl lying in front of me is Shweta. She is working as an HR.
Dr. Rupal, we can't hear you. Yeah.
Can you hear me now?
No, it's okay.
Is this okay?
It's okay. You can continue.
Yeah, I just thanked you for the generous introduction. Is it okay now? Are you able to hear me?
Yes.
Yeah. The girl here is an intelligent-looking pretty girl, Shweta. I don't know if you're going to be able to see her face, but she's already smiling. And she is working as an HR personnel. And we are fortunately having the right corneal curvatures and everything quite proper. The thickness is also 542. So we are going to be able to leave behind at least 363 microns of non-touch tissue. And I think without much ado, we can start unless you have some questions.
No questions, you can start.
Yes, thank you. We have used 2 drops of Propercan eye drops and an antibiotic eye drop. We are in the process of draping the eye. We'll put it later, once we put the thing on that time. Shweta, try and keep your eyes closed only right now. Is it hurting you? I'll tell you when to open it. The machine runs a self-test. So once that's almost over, we'll open your eye. It takes about 20 seconds to run it. So once that is done, we will start. Okay? I'll tell you when to open it. I'm right now raising and getting her in position so that once the eye is open, we don't need to raise her too much. This is the cone that I'm applying. 1 cone is used per eye. The machine runs a self-test, and only once the self-test is over, it allows you to go further. That's an inbuilt safety mechanism. Shweta, can you open your eyes, please? I'm putting something which will help you to keep it open. You'll feel as if somebody is pulling it open. Is that right? Yeah, this is going to be the worst part of the entire procedure. Okay? You're not going to get more pain than this. Is this comfortable for you? Okay. You'll see a green light in front of you. It will come closer and something will come and lightly sit on your eye. After that, don't move for the next 30 seconds. Okay? Once you see the green light, please let me know. I'm aligning and getting the green light exactly in the center of the white blur. And once the patient is looking straight ahead, it's going to be also at the visual axis. Shweta, you can see it now, right? Just keep looking over there, please. It's okay. Keep looking straight, Peter. You're doing well. So we see we are well in center. Now you please calculate in your mind till 30 seconds, okay? Whether you see the light or not is immaterial. Try not blink, okay, bete? You may not see the light, don't talk, don't move, don't try to squeeze your eyes, please. We are more than halfway through. That's the 4 millimeter incision. This is the actual time it takes to finish both the passes as well as the incision. So now we can move her to the operating microscope, which is attached to the laser itself. So now she's under the operating microscope. Shweta, was this okay? Did it hurt you? No. You were superb. Is this hurting you, Betty?
No, ma'am.
Okay. Just let me know if it starts hurting you, okay? Now you can't see the light so well,
Yeah, ma'am.
but you still have to look at that blur. I'm just changing the speculum because the eyelashes tend to come in the way. Is this okay, Betty?
Yeah, ma'am.
Okay. Keep looking straight.
Okay.
Yeah, perfect. Is this in the center?
Yes.
I'm opening the incision and going inside, but making sure that I'm remaining on the superficial plane. And then I also like to make the opening in the bottom so that I'm sure that I have 2 layers with me. This I do on the side. So if you can see now, there is, can we make this 1.6? We have 2 openings. Yeah. Is this better?
Yes, better.
Okay. So if, I don't know if you can notice, but this is the incision, and that's the small little opening that is there, which takes us beneath the lenticule. So what I'm going to do is avoid that part and go on the other side to go and separate the tissue which is lying above the lenticule. And as you can see, it's a very easy separation. Once I've done that, I'm going beneath through that other opening that I made. And as you can see, as I'm separating the lenticule, it starts showing a line of separation on the side. Shweta, if you're uncomfortable, let me know, huh, bete?
No, ma'am, I'm comfortable.
Now, as you can see, we have the entire lenticule which is separated. So we just need to grasp it and deliver it through that small incision. Once you have a good grasp, it just gets delivered out quite easily. And then we just need to wash on top and make sure that the incision is adhering well. I don't like to go in the pocket and wash. I don't like to introduce anything in that space, not even fluid, because you ultimately then need to remove it. Once you close the lip of that incision, can I have a dry one, please? You can squeeze that and give it. No, just one. No, it's done. No more parakin. No more parakin, right, Sweta? No pain. And as I told you, the patient, the eye, and yourself can smile together. You don't need to wait because there is no flap to adhere. You can immediately close the eye and go on to the second one.
Dr. Rupal, anytime you have found any difficulty
your
in,
Open, please.
hello?
Yes, yes, I am hearing.
Anytime you have found difficulty in removing the lenticles in people with low myopia,
Uh,
0.5, 0.75, because the thickness may be less there.
Yes, fortunately I have not found that difficulty, and in fact we also have the next case where we have very low myopia, I think 1.75 diopter to be treated, and you'll see how easily there also the lenticule can come out.
Is
The
dissection
separation
difficult in,
is very good, and therefore it's easier to, but you do need to be a little more careful in that case, because you can have a slight tear at the margins. Please do that. It's Shweta, you're superb. You're really able to cooperate well. One eye has gone off perfectly well. It's not paining or anything, right? Okay. It's okay.
Rupal, congratulations. A beautiful surgery. We could see all the details of
Yeah,
the
I'm so
procedure
glad.
from here.
But I think once the second eye is done, Shweta also is going to need a round of applause. She's wonderful as a patient.
Can you take some questions in the meantime?
Yeah, sure. We're just preparing the other eye. We're draping the other eye.
Okay.
The other eye has been already been told, -4 with 0.5 cylinder. So we have a residual bed of 366 after making a cap of 100 microns, since the total thickness is 542. We'll first put the thing and then we'll put the speculum. Shweta, same thing again, but again the machine will run a self-test and we'll start again, okay? So right now, if you want, you can keep your eyes closed or open. 15-20 seconds is all that's going to take, okay?
Can I close it or what?
Yeah, you can. Whatever is comfortable for you. Can we start? Okay.
Yes.
I'm going to put something which will again keep your eye open, right? At this stage, if you are uncomfortable, you should let us know so that we can put more anesthetic drop, okay, Vijay? Is this okay?
Yeah, ma'am.
So the only thing is when the laser is going on, there's a little watering that occurs because probably you are trying to squeeze. So if you can avoid that, that would be better, okay? Because that can make the contact glass loose. Is that okay? You'll again see a green light. It will come closer. Something will lightly hold your eye and then will not move for the next 30 seconds, right? You're looking very well at the green light. That's beautiful. Just keep looking straight, Peter. Count till 30. Ten seconds done, so 20 seconds more to go. If you don't see the light, it's all right. Yeah, you please don't speak. Just keep looking straight. You're doing very well, Shweta. It's wonderful. It's almost coming to an end. 5 seconds more to go. That was beautiful. Very well done, Beta. You okay?
Yeah, ma'am.
Perfect. Now we just need to remove that lenticule from there, right? Now we are again getting her under the surgical microscope. As you can see, the depth perception is pretty good. What you see here are the footmarks of the contact glass. Since she has a very small cornea, the footprint of the contact glass is almost going on to the conjunctiva. But otherwise, it usually remains confined to the cornea. That's why you could see a little watering that occurred there. Now again we open the incision. ये कुछ है. Just a swab, please. Go in, find the plane above the lenticule. Some amount of bubbles get released because of that, so your visibility increases. I like to keep a small gap between the outer and the inner edge, so that even without view I can make out where the edge is of the lenticule. Once I have separated that edge also to a small extent, then I again go above the lenticule. This step is important. Only if you are sure that you are above the lenticule, you should go ahead and separate it. Because by chance, if you are under, then this separation will make the lenticule stick to the top. And you should not use any force at all. The separation is pretty good. So I'm simply putting the instrument within the cornea and moving it around. You can actually see the lines developing on the side. So as you can make out, this much lenticule has been separated. The other half is remaining to be separated. So I go on the other side in similar way. It's important to feel the give way at the lenticule edge, because that would mean that you have separated the edge. Once you've done that, again very easy to just grasp and remove the lenticule from there. This is a special forceps. We had designed it from internal limiting membrane peeling forceps, which helps you to hold even the thinnest possible lenticule. So as you can see, you can deliver it out very easily. This was about 70 odd microns of lenticule thickness. And that's the end of the procedure. Yeah, the claps are for Shweta. You were superb, Betty. Really good. I would just like you to see the other eye that we've operated, because here you may find that there is a little bubble and the cornea doesn't look as nice as we want it to look, but that's because of the bubbles which are present. If we look at the other eye, all the bubbles would have been gone, and then you would be able to make out how clear the cornea looks immediately on table also. I would also like you to see the slit lamp attachment, which gives a nice view of the, as you can see, the cornea looks sparkling, as if nothing has been done. And if you look on the slit lamp, this is a slit attachment. A line nahi hai. Can you come a little? It's not a line. It's not aligned. If I align this, that's not getting aligned. Let's see this side. Yeah, karte hain. Look straight, please, Shweta. Yeah, that's nice. You can actually run the slit. Now I'm washing out only. And you can see the two edges. This is the left eye, so you can still see some bubbles. Blink, please. Right? Okay, thank you. Antibiotics, please. Don't try to get up right now. You will have to touch this because now I'm unsterile. Beautiful. Well done.
Yeah, thank
You show her when she's going. Ask her how she feels.
Dr. Rupal?
Yes.
Yeah, wonderful surgery. We just wanted to know the diameters of the posterior ablation and anterior ablation, the overall diameter. Can you hear us?
I can't hear you very clearly. Just a moment, the patient is getting up, so if we can just have a look at her. Shweta, you have to give a good smile. She's now smiling not only with her lips, but with her eyes.
There are
In the
three
true
smiles,
sense.
two in the eye and one in the face.
Yes. Well done, Shweta. Yeah, a round of applause for you. You should. It was such a pleasure.
you. Yeah, ma'am, thank you.
Thank you.
Thank you, ma'am. Thanks a lot.
Are you able to see
Yeah, ma'am.
enough to go out by yourself?
Yeah, I can go.
Can you focus on her eyes, how quiet it looks? The eyes look almost as if nothing has been done. Thank you. Pleasure to meet you. You were really super. It's very difficult to keep your cool in there. Good. There was a question, right? For her.
Okay, the question is the diameter of the ablation, the fronto-laser
Her
ablation.
pupil size was 5.4, so we decided to make the optical zone as 6 and the cap size as 6.75.
What is the incision size here?
I made a 4 millimeter incision. I normally make a 3, but in this circumstances I thought it was better to make a 4 for my comfort.
Well, what do you do with the lenticle that you remove? Is there any way you can use it, or do you preserve it, or do you throw it out?
Right now we are throwing it out with a very heavy heart, but I'm sure that in future we would be able to find some use of this precious corneal tissue. So, once more people apply themselves to this, I'm sure we would have some productive use of this precious corneal tissue. There are some researches which are going on where they are trying to preserve this, and I know that at Singapore Eye Institute, Dr. Donald Tan is preserving this tissue and have also re-implanted it in rabbit's eye. So they are doing an animal study stage, and they found the refractive error to be almost coming back to the original, which means that it's retaining all the characteristic as normal. I don't know whether we'll be able to use it for strengthening some weak corneas or to maybe treat a hyperopia or whatever. But I'm sure that if you don't need, every time I throw that tissue away, I'm really feeling very sad about it.
Can they be used for patch graft, and the corneal surgeons should be able to use that material
I'm
for
sure
ulcer?
we can make some use of this material because it is a live tissue. So
Are you worried about...
I
you're
have not tried
washing-
anything of that sort.
No. What the next question was, you're not washing the interface.
Yes.
Like in a LASIK, interface is cleaned and then, you ablate it and
Yes.
clean it again and put the flap back.
Yes.
Are you concerned about it because there is a layer, there is an ablation, there is a plume which sits there,
Yes.
and there are two layers.
Yes.
Are you worried about some amount of the necrotic dead tissue leaving behind in that?
No,
Or you're
here
not-
I don't expect any debris to be there. In fact, I was washing that pocket, but I've stopped washing them from now. And that's because I don't want anything to be introduced inside the eye. You are using sterile instruments which are totally dry to separate the lenticule from top and bottom. You're not really entering inside after that. And the laser is focusing and forming plasma formation. So there is nothing that is getting introduced from outside. Like in a microkeratome, you would be taking few epithelial cells or also some debris from outside. And once you open the flap, both surfaces, the flap as well as the stromal bed is open and to the conjunctival fluids and to the atmosphere, which then can cause something to get deposited there. Here, because we are working in a closed system, I found that nothing was coming inside, and therefore there was no point introducing some more fluid and then taking it out, because it would not make sense. We have not had a single case of epithelial ingrowth. If you look at the cornea, the next day they look sparkling, and after a week or so, it's even difficult to make out that something has been done in this eye.
Okay, I see a huge difference in the approach. Excimer lasers ablate around the pupillary center. Here, pupil is a non-issue, as I've seen. It's a docking is the issue. The patient is looking at the green light, gets docked, and does it monitor the pupil, or pupil is a non-issue here?
No, we should in fact not modify the pupil, because in case the person cannot just look straight in the light, because not everybody is as cooperative as Shweta was, at least you can then center in the center of the pupil. So it's better not to middle around with the pupil. You should leave it in the normal way. So if at all you can't fixate on the visual axis, at least then you are fixating on the center of the pupil, which is the next best thing to do.
No, when you're docking it, does it dock around the pupil, or does it dock around the visual axis, or where the patient is looking at?
It will depend upon where you are putting that green point on. So if the person is looking straight ahead, and if you are then fixating the green point exactly at that point, then it's a visual axis. But you can move and put the green point exactly in the center of the pupil, and that would be then an optical axis.
Is the ablation profile aspherical? Is an aspherical profile, or
The ablation profile is an optimized one. It's not an ablation, it's actually carving out the lenticule, but that's an optimized profile, a wavefront optimized profile, which induces the least aberrations.
And how forgiving is the decentration in this procedure?
It is more forgiving than in a LASIK procedure, and that's because there was an explanation to that, because we found that visually patient is not really getting affected. If you look at the topographies, you would, if you are careful about centration like what you saw, we also go and see on the infrared, then it's usually bang center. If it is decentered due to any reason, it would be working almost as a decentration in an excimer laser. Here, because the area is small, significant decentration is not likely to happen. Just like in an excimer laser, because it's tracking the pupil or the limbus, today you would not really find significant decentrations. But it is quite forgiving to small amounts of decentrations.
Okay. Thanks. I think you will have to go on to the next patient.
Thank you
if
so
I'm right.
much.
Thank you.